My name is Mike. I'm the Director of Medical Affairs at Dr. Shar USA. Thank you for attending our first webinar. We are excited to launch this new continuing education program at Dr. Shar USA. Today's presentation will be delivered by Megan Donnelly, who is the company's registered dietitian. She's based out of New York City and has worked with the company for nearly 1 year. Her specialties are in chronic kidney disease and gastrointestinal disorders. I want to quickly address a few logistical items before we get started. First, your certificates of participation will be emailed to you after the webinar has ended. This webinar has been approved for one CEU by the Committee on Dietetic Registration. If you do not receive a certificate via email, please email Megan, whose email is on this slide. We will also be recording the webinar and posting it on the Dr. Shar Institute website for on-demand viewing. All the DSI information will be provided in the email following this webinar. Feel free to type your questions throughout the presentation in the QA tab, and we will address them at the end as time permits. If we do not get to your question, we will follow up via email. With that, I'll turn it over to Megan.
All right, thank you, Mike, for that introduction. As Mike mentioned, I'm happy to answer any questions at the end of the presentation. And now I'm going to present to you today's lecture titled Medical Nutrition Therapy, Promoting Kidney Health in Patients with Chronic Kidney Disease. Here is an overview of topics I will be discussing today. First, we will go over the disease burden in chronic kidney disease and end-stage renal disease in the U.S., followed by medical nutrition therapy with protein restriction, also known as the low-protein diet. Then we will touch on incremental dialysis, other components of MNT for patients with CKD, safety of the low-protein diet, and medical nutrition therapy in practice. After the Q&A, we will also have some information that addresses food solutions for CKD patients. And now let's begin with disease burden, CKD, and ESRD in the United States. As many of you probably know, CKD is a global epidemic. For our purposes today, this presentation will focus on the United States population, although CKD is prevalent in many nations throughout the world. In the US, almost 15% of the adult population suffers from CKD. In fact, patients with moderate to advanced CKD, which is typically defined as stages 3 through 5, make up just over 7% of the US population. CKD is a progressive disease, which means it gradually worsens until it reaches end-stage renal disease, which requires some form of renal replacement therapy. Only about 0.2% of CKD patients survive to reach ESRD. Currently, over 500,000 people in the US have ESRD and require renal replacement therapy in the form of peritoneal dialysis, hemodialysis, or kidney transplant. Two of the main contributors to CKD development are hypertension and uncontrolled diabetes, specifically diabetic nephropathy. Individuals with CKD also have a high risk of cardiovascular disease, which is a main cause of mortality in this patient population. There are currently over 700,000 people in the US who have ESRD. About 70% of these individuals currently receive maintenance dialysis treatment, while about 30% have received a functional kidney transplant. The total annual cost of end-stage renal disease treatments in the US is estimated to be over $27 billion per year. This translates to about $90,000 spent on medical treatments per patient each year. It's very expensive. In addition, the survival rate is somewhat unfavorable. Only 78% of the patients survive the first year of end-stage renal disease treatments, including dialysis and transplantation. This worsens over time, and sadly, after 5 years, mortality reaches about 50%. There are two main areas that I'm going to focus on today. One is the importance of medical nutrition therapy for CKD management to slow the progression of the disease. The other is incremental dialysis, which involves a gradual transition to dialysis. Incremental dialysis may not be something you have seen in your clinics yet, but it is important to note that this method is practiced in other countries all over the world, including Italy. All right, so now we'll get into the MNT with protein restriction, which is also known as the low protein diet. A low-protein diet regimen usually includes 0.6 to 0.8 grams of protein per kilogram of ideal body weight per day for a given individual. I would like to point out that a low-protein diet for pre-dialysis CKD management will be a key component of the soon-to-be-released KDOQI guidelines update. It is recommended that at least half of the daily protein intake come from high biological value sources. It is critical that the low-protein diet be implemented in conjunction with sufficient calorie intake. Another benefit to the low-protein diet is that it is inherently lower in sodium and phosphorus, which are two other components of MNT and CKD that I will discuss later on. It is also important that the low-protein diet plan include high fiber content with adequate fresh fruits and vegetables. Ultimately, such a low-protein diet will help prevent protein energy wasting or malnutrition, and it should help in management of uremia. The main goal is to preserve residual kidney function, which can delay the start of dialysis and improve quality of life. And as I previously mentioned, the low-protein diet is expected to help with management of uremia, which is the result of accumulation of uremic toxins on kidney function over time. I'd like to emphasize the importance of preventing protein energy wasting in this population. Per definition, protein energy wasting pertains to a condition where nutrition requirements and catabolic alterations in CKD happen as a result of losses in protein and energy stores. We know that protein energy wasting is very common in CKD patients, affecting about 20 to 25%. In more advanced stages of CKD, however, including end-stage renal disease, up to 75% of patients may suffer from protein energy wasting. Across all stages of CKD, protein energy wasting is a strong predictor of poor outcomes, including high mortality, low quality of life, increased hospitalization rate, and increased risk for cardiovascular events. Therefore, it is important to ensure that protein energy wasting is considered when planning a dietary recommendation for CKD patients. And later on, I'll get into a little bit more and discuss how to prevent protein energy wasting in the context of a low-protein diet. So this slide explains the proposed biological mechanism behind the efficacy of a low-protein diet and its effect on the kidney. As you can see, the intraglomerular pressure inside the glomerulus, this tuft of capillaries right here, is targeted to preserve the longevity of the nephron. One way to lower intraglomerular pressure is by lowering the amount of protein in the diet, which leads to vasoconstriction of the efferent arteriole, and in turn lowers intraglomerular pressure. Another mechanism that may reduce intraglomerular pressure is to lower systemic blood pressure through a low-sodium diet or medications. Angiotensin converting enzyme inhibitors and angiotensin receptor blockers can modulate vasodilation of efferent arterioles, reducing intraglomerular pressure. Taken together, a decline of glomerular pressure in the short term leads to a temporary reduction of glomerular filtration rate, also known as GFR. In the long term, kidney function stabilizes, which protects the kidney and leads to slower progression of CKD by reducing damage to the nephron. And here's that mechanism right there. The low-protein diet for CKD management is a concept that has been studied for many years. A landmark study was performed as early as the 1980s, the results of which were published in 1994 in the New England Journal of Medicine. It is called the Modification of Diet and Renal Disease Study, or the MDRD study, which followed patients over a 6-month period and compared a low-protein diet to a regular diet. This study showed that there was somewhat greater decline in the GFR in those who received a low-protein diet in the first 3 to 4 months of the study period. After the initial period, which was also consistent with what we discussed in the previous slide, the low-protein diet led to a short-term decline in GFR. However, the progression of CKD was slower after the 4th month. After combining the first 4 months with the remainder of the study, however, there was no statistical difference between the low-protein diet versus normal protein diet in terms of progression of CKD progression to ESRD, or death. The inconclusive results were rather disconcerting. If this is the case, why would the new guidelines be making recommendations for a low-protein diet in CKD? Well, upon further analysis, there were potential limitations that may explain the MDRD study results. As we discussed, the low-protein diet lowers intraglomerular pressure in the short term, which leads to reduction in GFR. This seems like it would be a bad thing for kidney function. However, that decline in the short term ends up being protective in the long term, which the researchers did not account for. Additionally, the duration of the study was only 6 months. There was no official follow-up, but many secondary analyses were performed after publication. In these analyses, the low-protein diet in general was shown to be associated with favorable outcomes up to 6 years later. In the MDRD study, it is also important to note that patients with diabetes were excluded if they were receiving insulin. This is problematic because diabetes is a very common comorbidity among CKD patients. Finally, the MDRD study had a disproportionately large number of CKD patients with polycystic kidney disease. Up to a quarter of MDRD patients had polycystic kidney disease, which is already known to have slow progression and therefore may not be as responsive to a low-protein diet within short periods of time. So, taken together, these issues may explain why the MDRD study did not generate the expected positive results, even though the long-term analyses and secondary analyses suggested that the MDRD study was indeed positive in terms of proving the benefits of a low-protein diet in the CKD population. More recent studies, such as this one published in 2014 by Dr. Giordano and colleagues, have compared the efficacy of a low-protein diet versus a normal protein diet. In this study, patients with CKD stage 3 to 4 and type 2 diabetes were divided into 2 groups, either low-protein diet of 0.7 grams of protein per kilogram of body weight per day, or those who maintained their normal protein intake, which on average was about 1.1 grams of protein per kilogram of body weight per day. The results of this study over 36 months showed that diabetic patients with CKD stages 3B to 4 who maintained a low-protein diet had significantly slower disease progression, which you can see here in the figure on the left side. Additionally, proteinuria, which we know is an important prognostic factor for kidney damage and disease progression, improved significantly over time in the low-protein diet group compared to the normal protein diet group. This data suggests that the efficacy of a low-protein diet in diabetic patients with CKD is beneficial. The data on this slide is from a study that was conducted by Dr. Bernori and colleagues. In this study, a group of elderly individuals who were supposed to start dialysis were randomized into 2 groups. One group transitioned to dialysis as planned, whereas the other group, instead of transitioning to dialysis, maintained a very low protein diet supplemented with essential amino acids. In this case, the very low protein diet was defined as 0.3 grams of protein per kilogram of body weight per day. The group that maintained a very low protein diet without dialysis had somewhat similar outcomes, including survival. An important outcome was that the number of hospitalization admissions and length of stay were lower in patients who maintained the supplemented very low protein diet compared to those who transitioned to dialysis. Not only does this suggest that the very low protein diet implementation is safe in this population, but it also suggests that very low protein diet with essential amino acid and keto analog supplementation may actually be superior in terms of reducing risk for hospitalization and reduced length of stay. This study assessed the impact of implementation of medical nutrition therapy by a registered dietitian. The researchers compared 2 groups, those who received MNT under the direction of a dietitian and those who did not receive any MNT. They measured average time to dialysis over a 10-year period, and the results showed significant differences between the 2 groups and that the average time to initiation of dialysis was faster in those who did not receive the MNT. Patients on MNT were threefold less likely to be initiated on dialysis. So, this study provides further evidence that dietitians are key members of the healthcare team and can facilitate improved patient outcomes. Okay, here I'm going to highlight a meta-analysis performed by Dr. Folk and colleagues in 2009. This is essentially a pooled analysis of prior clinical trials that compared a low-protein diet versus normal protein diet. The analysis showed that in 9 out of the 10 studies, there was a trend towards decreased incidence of renal death, which is defined as progression of CKD, patient death, or start of dialysis. They also showed an overall 32% reduction in relative risk for renal death with a low-protein diet, providing further evidence that a low-protein diet was effective in slowing CKD progression and improving outcomes. Okay, and now I'm going to transition our focus to incremental dialysis therapy, which I know is a new topic for many of you. For those of you who don't know, incremental dialysis involves the gradual transition from advanced stage CKD to dialysis. Instead of immediately starting patients on 3 times per week full-dose hemodialysis, they are offered a gradual transition by means of hemodialysis once or twice a week. Studies such as this one by Dr. Lin suggest that a gradual transition to dialysis, including twice-weekly hemodialysis treatment, preserves residual kidney function for longer and is associated with acceptable clinical outcomes and adequate safety. Dr. Belasco and colleagues compared the value of combined low-protein diet on non-dialysis days with once-weekly dialysis therapy, as opposed to the conventional maintenance hemodialysis method we use here, which usually takes place 3 times per week. The results suggested that patients who transition incrementally with only 1 hemodialysis treatment per week, while maintaining a low-protein diet on the other 6 days, had greater survival, as shown here in this figure. Hence, combining a low-protein diet with incremental dialysis may be a more desirable way to transition to dialysis treatment. As I mentioned earlier, this approach is uncommon in the United States, but has gained some traction in other countries like Italy, and I think we may start to see it here in coming years, especially if it improves patient quality of life. All right, and now for the dietitians on the call, we're going to get into the details of MNT for CKD management. Now, the goal of MNT is to ensure adequate nutrition support while targeting certain nutrients for restriction depending on clinical status. For CKD, these nutrients typically include protein, sodium, phosphorus, fiber, potassium, and fat quality. All right, we've been talking a lot about protein. Protein intake is a cornerstone of MNT in CKD patients. As we have been discussing, the goal of a low-protein diet is to consume less than usual dietary protein, which is actually quite high in average American diets. The current recommended range for CKD is 0.6 to 0.8 grams per kilogram of body weight per day, though this may be reduced even further once the new KDOGI guidelines are published. Half of that protein should come from high biologic value sources. High biologic value proteins are more readily absorbable through the gastrointestinal tract and offer higher delivery of essential amino acids. Some examples of high biologic value proteins include meat, eggs, milk, soy, whey, and some legumes. The risk of malnutrition is reduced by adequate caloric intake and consumption of high biologic value protein sources. Essential amino acid supplementation may be necessary, especially if patients are following a very low protein diet regimen. Okay, this slide highlights the importance of reduced sodium intake. According to the National Kidney Foundation, daily sodium intake should be restricted to 2.4 grams of sodium per day or less. Additionally, the recently published guidelines from the American Heart Association and American College of Cardiology recommend less than 1 gram of sodium per day for those with hypertension, which we also know is a common comorbidity in CKD patients. This has beneficial effects in terms of blood pressure management as well as proteinuria. A low phosphorus diet may be necessary as kidney function declines. Usually a low protein diet, if designed well, is also inherently lower in phosphorus because many of the high protein foods are also sources of phosphorus. Hence, a low protein diet and low phosphorus diet are typically quite consistent and aligned with each other. Higher phosphorus intake is associated with progression of CKD and may cause cardiovascular and bone-related damage, including vascular calcifications and renal bone disease. Adequate fiber intake is also critical in this population, and as we know, most Americans in general do not consume enough. Dietary fiber comes from intake of plant-based food sources, including fresh fruits and vegetables, and frozen and canned as well, whole grains, nuts, and legumes. It is important that adequate fiber is consumed given its association with improved gut microbiome modulation, which may lead to lower generation of uremic toxins. It may also reduce risk of hyperkalemia and hyperphosphatemia. Also, dietary fiber intake of 25 to 30 grams per day is consistent with higher intake of protein from plant sources, which is desirable in this population. Dietary potassium restrictions may be necessary if the patient is hyperkalemic. Patients with mild to moderate CKD should limit potassium to 4.7 grams per day. With advanced CKD, dietary potassium may need to be restricted below this amount, and it may even go below 3 grams per day if hyperkalemia persists. Potassium restriction should be individualized based on serum levels and given under the direction of a physician. CKD patients should consume mostly mono and polyunsaturated fats as opposed to saturated fat because of cardiovascular disease risk and presence of hyperlipidemia. Since a low protein diet usually means that the contribution of protein is less than 10% of the daily diet, over 90% of the energy comes from carbohydrates and fats. It is very important that carbohydrates be complex carbohydrates and that the fats are healthy fats, which include those mono and polyunsaturated fats as noted here. This will ensure that other blood panels remain within normal limits. Okay. As we have gone through all of the components of the diet, it is important to understand how to effectively implement the diet and manage CKD for each individual patient. Effective CKD management involves a multidisciplinary approach and healthcare team. CKD medical nutrition management ideally includes frequent monitoring by nephrologists and registered dietitians who specialize in this type of medical nutrition therapy. The successful implementation of MNT requires consistent communication with the dietitian to improve dietary adherence and help patients work through the challenges they may face as they attempt to implement this highly complex diet. This is even more important given the fact that there is a higher rate of malnutrition in CKD patients with disease progression. Dietitians and nephrologists should work together to ensure that the dietary regimen is individualized for the needs of each patient, and they should prioritize adequate energy intake and monitor adherence through lab values. When speaking about the low protein diet, the biggest questions I get from healthcare providers are, is the diet safe, or what about malnutrition? So now I'm going to dive into some of the research and hopefully show you that a thoughtfully planned out low protein diet is in fact safe for CKD patients. Many studies, including the MDRD study and others we have discussed, report low rates of malnutrition among individuals following a low protein diet. These findings suggest that it is highly unlikely that a low protein diet leads to worsening protein energy wasting when it is implemented correctly. In fact, metabolic responses to dietary protein restriction include increases in amino acid utilization, which effectively means that amino acids can be more efficiently utilized for necessary processes, such as building and maintaining lean body mass, Additionally, amino acid oxidation is decreased and protein degradation is diminished when dietary protein intake is lower. Hence, there is a sort of metabolic stability. In general, the most important factor for preventing malnutrition risk is ensuring that the patient has adequate energy intake, which equates to calories from food. To recap, reduced protein intake range of 0.6 to 0.8 grams protein per kilogram of body weight per day is typically nutritionally adequate and safe for CKD patients. If the amount of protein recommended to the patient is lower than 0.6 grams per kilogram of body weight per day, such as that 0.2 to 0.6 very low protein diet, essential amino acid or keno analog supplementation may be necessary to preserve nutritional status. Okay, now I'm going to highlight medical nutrition therapy in practice and why dietitians are instrumental for implementing these dietary changes and improving clinical outcomes. Dr. Campbell and colleagues highly recommend dietary counseling to patients with CKD who are not on dialysis. This counseling plays an important role in the clinical outcomes for CKD patients. In this study, patients were divided into two groups. One group received proactive dietary counseling by dietitians in terms of a low-protein diet, and the other group attempted to implement the low-protein diet independently. At the end of the 12-week study period, malnutrition rates were significantly higher among those who did not receive dietary counseling from a registered dietitian. This study highlights the importance of dietitian involvement and provision of dietary counseling by a registered dietitian. Registered dietitians are truly experts in this area and have the skills to work closely with the patient, provide individualized recommendations, and provide practical applications of the diet to each patient. Now, I'm sure that most of us on this call agree that dietitians are essential members of the CKD management team. Unfortunately, however, this study shows that about 88% of patients do not receive any dietitian care prior to dialysis initiation. Only 9% of patients with CKD receive dietitian care for less than 12 months, and only about 3% receive care for longer. Nephrologist involvement has a somewhat similar profile. Both of these may be related to the fact that individuals with early stage CKD often do not present with any symptoms and may not be aware that they even have any kidney damage. However, this study also identified that many nephrologists stated that their main reasons for not referring patients to dietitians were lack of access to a dietitian and perceived cost burden to the patients. I'd like to address both of these here. In terms of lack of access to a dietitian, it is critical that RDs promote themselves to nephrologists to increase referrals so that they can help patients with earlier stage CKD. Also, CKD is actually covered under Medicare Part B for CKD patients for 3 visits per year during the first year and 2 visits per year in subsequent years. So really, there shouldn't be cost to most patients. Dietary adherence is key to the success of a low-protein diet, but of course there will be challenges when implementing this complex diet. Adherence is challenging across the board in U.S. healthcare. In fact, almost half of the patients in the U.S. are not adherent to their medication regimens, so obviously it would be challenging to get them to adhere to dietary regimens. Such propensity for non-adherence may be improved through awareness that medical nutrition therapy may delay dialysis at all CKD stages. Therefore, regular involvement of dietitians is needed, and as discussed, dietitian counseling is very important to support patients and their families. In order to maintain dietary recommendations over time, a low-protein diet should be acceptable to the patient, varied, and personalized. Okay, now we will discuss the key takeaways and conclusions before our Q&A portion. As a reminder, once the Q&A concludes, I would like to mention our food solutions, which will help facilitate a low-protein diet more effectively. In summary, CKD is a national epidemic affecting almost 15% of the US population. The management of advanced CKD is very expensive and costs about $27 billion per year. Medical nutrition therapy with a low-protein diet maintains residual kidney function and reduces the risk of renal death. Successful implementation of or adherence to medical nutrition therapy depends on individual dietary recommendations tailored to the needs of each and every patient with CKD. This requires increased involvement of registered dietitians. Low-protein diets with adequate energy intake are safe, meet the dietary requirements for patients with CKD, and ensure that the requisite amount of protein is consumed. Implementing a low-protein diet with incremental dialysis is a novel approach that has been pursued in a number of studies in other centers throughout the world. It involves gradual transition to dialysis, which may be more favorable for patients, along with maintaining a low-protein diet on non-dialysis days. Okay, and now with that, I'll ask for questions from the audience. So I believe you'll be able to type them in the box. So we'll wait a few minutes for any questions.
Okay, so we have a question. What lab work would you recommend with regards to diagnosis of chronic kidney disease? The standard is usually a blood test, blood for looking at levels, blood looking at also nephrologist.
Yeah, also creatinine.
Please.
And then they'll also check for some of those micronutrients like phosphorus and potassium levels as well. We have another question that says, could you repeat the cost for patients who have Medicare Part B and number of RD visits? So in that case, all that would need to happen is that there needs to be a confirmed diagnosis of CKD, and then the doctor writes the referral with that diagnosis, and they get 3 visits per year that are covered by Medicare. So 3 in the first year, and then in the second year, they get 2 visits, and then 2 visits each subsequent year. So it's actually something a lot of people don't realize, that they can refer for MNC in CKD, and the other condition is diabetes is covered. Okay, we have another question. Vegetarian diets, do the studies show enough high biologic value protein intake for them? What about vegan? So actually there's a lot of evidence that suggests that vegetarian diets are actually helpful in this population. In terms of getting the high biologic value protein, I think they can get enough. It just requires a little bit more of working with complementary proteins. So things like, complementing beans and rice, that'll deliver a better amino acid profile than just consuming the rice alone. So I think it takes a little more creativity, but vegetarian diets are actually very beneficial in this population. It helps them reduce their protein intake right off the bat. It improves the fiber intake, and they're also, plant-based diets are shown to be pretty anti-inflammatory. So overall, it should improve patient outcomes if they focus on vegetarian diets. As for vegan, I think kind of the same thing applies. It might take a little bit more creativity to find some of those complementary proteins to deliver all the amino acids, but I think it can be done. But again, this would require a dietitian to help. I mean, patients wouldn't have this kind of ability on their own. So thank you. Do we have any more questions?
So if you have any further questions, email.
Oh, we got
Oh,
one
we
more.
have one more. Phosphorus recommendation.
So again, that will depend on the patient, but typically it's under 500 milligrams per day. Phosphorus is one of those that really kind of depends on what's going on with the overall clinical picture of the patient. So it'll vary, and it will probably be set by the physician.
Well, thank you. Any trendy supplements?
It's funny, I actually just went to a presentation about dietary supplements and CKD. I don't know about trendy, but some of the ones that were mentioned as possibly beneficial, and there's some evidence that supports their efficacy for different reasons, are curcumin and cinnamon supplements. But I encourage you to do more research on that. There's good databases out there like the Natural Medicines database, and even just there's some dietitians who do a good amount of research in them, such as Jessiana Seville. If you look up her blog, I'm not an expert on dietary supplements, but those are just a couple that I've heard have been effectively used in this population.
Also, don't really require
Yes, it's always a good point. Check who your manufacturers are and look for third-party testing labels on all supplements. Okay, can you recommend a source for handouts in patient education? Yes, so we are going to talk about it in a minute, but the Dr. Shar Institute has a variety of downloadable patient handouts and educational resources that I will be providing the link at the end in the email with your certificate, but actually you can go in, see the resources, and download them and reprint them to use with your patients. So we have a lot. Also, the National Kidney Foundation has a lot of patient education handouts, and so does the Academy of Nutrition and Dietetics.
a lot of
Yeah, we have a lot. Oh, okay. What about patients with edema to the bilateral lower extremities with low albumin levels less than 3 grams? Would you still do a low protein diet? So just to clarify this question, would they be is this a stable patient? It sounds like if they have edema, they're probably in a more inflammatory state. My general way that I approach this is that the low protein diet really should be for the stable CKD patient. If they have something else it's an inflammatory process that's causing them, causing the low albumin and the edema, then probably it's not a good time to be restricting the protein because there's something else going on that's probably increasing their needs. So I would be careful to do a low protein diet. However, once this inflammatory state is resolved, then potentially they could go back to it. Okay, so I think with that, we'll wrap it up. So again, if you have questions, you can definitely email me, and I'm going to turn it over to Mike to discuss a little bit about our sponsor today.
Thank you for this insightful QA session. I would like to take this opportunity to discuss food solutions that can allow for an easier implementation of an LPD. Dr. Shar, who has sponsored this session, is a company that specializes in food for people with special dietary needs. Dr. Shar launched over 30 years ago as a pioneer in a niche market for gluten-free products. And we are very fortunate that Dr. Shar products are now available for patients with CKD in terms of an LPD. Dr. Shar has global involvement in providing MNT for several disease states, including CKD. The Flavus line of kidney-friendly medical foods includes different products that are consistent with the recommended LPD for patients with CKD. These products ensure a variety so there is no diet fatigue in terms of the taste and other appealing features. The nutritional profiles of these products are consistent with the low protein, low sodium, low phosphorus, and low potassium recommendations for MNT for patients with CKD. Of note, many of them are also vegetarian and good sources of fiber. Thank you very much. Just quick acknowledgements. This is sponsored by Dr. Shar, Innovating Special Nutrition.